You don't get it. So what are parasitic diseases? Basically, they are infectious diseases caused or transmitted by a parasite. So the parasites will either live inside the host or on top of them. They will feed on either the internal organs or intestines, or they will just take blood off from the top, like mosquitoes or fleas, things like that. The three main types of parasites that we'll discuss is protozoans, helminths, and ectoparasites. And we do talk about a few endoparasites, but these are the main ones that they list as parasitic diseases. So you guys can already know what protozoans are. Do y'all remember that from way back in microbiology? You guys remember that? So they're the single-celled organisms. And then you have the helminths, which are the worm diseases, and then the ectoparasites, like fleas or mosquitoes that live on and feed on top of the host. So, and I'm sure, did Dr. Latassa kind of go over this a little bit with you guys on Monday, or no? Just kind of talked about transmission. So, you know, this is how we get parasitic diseases. So they're vector-borne. We're either bitten by a flea or a tick, mosquito. You can ingest it by eating contaminated foods, water, vegetation that's poorly washed or washed in water with feces in it. Penetration to the skin, so they can actually enter the body through breaking your skin. And then penetration of the eyes. You get droplets into the eyes, or the worms actually get in your eyes, which we're going to talk about today. And then sexual contact, and that's with the STDs like the Trichomonas that we have already previously talked about. So what puts you at risk of getting these? Didn't everyone tell you don't ever walk barefoot out in your backyard? That's one of the reasons, because you can get hookworms that way, so don't walk around barefoot. Inadequate disposal of feces. So that means in poor countries where sanitation is not a priority, or, you know, they just don't have clean water, is they bathe and they also wash their food in the same waters that they live in. Lack of hygiene, that's within that. And close contact with someone carrying a parasite. So again, living in small, poor communities, you're living with tons of people in one house, and you're in very close proximity to those parasites. And then insect bites, here and worldwide, that's the biggest issue. And then eating undercooked foods, and then unwashed fruits and vegetables. So these are the ones. So out of the topics today that we're not going to cover is the malaria, dengue fever, and the yellow fever. And the toxoplasmosis, have you guys had a lecture of that already? Okay, so that will go on to the next one as well. The first group we're going to talk about are protozoans. So we can already talk about what they are. So they usually multiply by binary division. So that's how they grow. They actually live in the hosts and cause bad diseases. So the protozoas enter the body usually by ingestion, and they are two different morphological types. Do these terms look familiar? Tryphocytes and cysts. So the tryphocytes are actually the feeding stage, and they are the active infective stage. And the cysts are more the hardy ones. They can live in the soils and stuff like that, or in the body for a while. They can also cause disease. And this is just a little slide about amoebas. So there are a few amoebas cause diseases, but the two that we'll talk about today are, and I think Professor Rourke will talk about one, Amebiasis histolytica. She'll talk about that one. But the two today we're going to talk about is Acanthamoeba and then Naegleria fowleri. Those are the two we're going to talk about. So Acanthamoebas. So these can cause infections in humans and in animals. These are found in waters, like water, swimming pools, air-conditioned duct units. I think they're also part of the listeria group too that can cause listeria. Usually these enter through cuts or scrapes when it breaks in the skin. But the two diseases we're going to talk about today is Acanthamoeba keratitis and then encephalitis. Who wears contact lenses in here? Minor dailies. Who has ever taken their contact lens out, put it in their mouth, and stuck it back in their eye?
So it holds out the basketball court. What else are you gonna do?
It happens. I see that.
See out of my left eye. I gotta put that one.
You do it all the time. You may not want to do that. Or have you ever taken it out and run it under the tap water and put it back in your eye? Yeah, no solution.
I've done that.
I confess. Last resort. So again, the Acanthamoeba lives in two forms, the parasites and then the cyst forms. So this is just a life cycle of the Acanthamoeba. So they, again, replicate through mitosis. And then under the right circumstances, they will turn from the trophozoite to the cyst. And then again, like I said, they either enter the body. With the Acanthamoeba, they can enter through the eye, breaking the skin, or through the nose. And then some of them can go up into the brain, which that one does, and causes the encephalitis. So that's just a nice little graph. All right, Acanthamoeba keratitis. So this is a rare, but it's a serious infection of the eye. You can be permanently blinded, or it can cause poor vision in your eye, permanent vision loss. And 85% of it's caused by contact lens wearers. And why do you think contact lens wearers are at risk?
Because it like presses it to their eye and holds the
Right? It can be trapped between the eye.
or hygiene your eye.
Hygiene. What'd you say?
Well, because like you're always touching your
You're
eye.
always touching your eye, but it's like, how many times has anybody put the contact, because you were out late and you didn't want to change out the water in the case of your eye contact lens, and you just pop them out and put them back into the water that was there from the day before? I've done that. So just improper handling, and then how many times do you take your contact lens out without washing your hands before you do it? And then how many sleep in their contact lenses or go swimming with their contact lenses in? So that's why.
See without us.
But water just come right through.
I just go without in my sunglasses.
So how would a patient with Acanthamoeba keratitis present? So kind of like someone who has a viral conjunctivitis or any other eye infection. They'll have pain in their eyes, like an itching or a sensation that something's in their eye. They have blurred vision. They maybe have excessive tearing, photophobia. So these are kind of hard to tell what's the difference between that and an Acanthamoeba infection. But a lot of times it's pain in proportion to the clinical findings is a classic feature of Acanthamoeba. But that doesn't always mean just lack of pain doesn't mean that they don't have the disease. So you have to take a good history with these patients. You know, if they're contact lens wearers, if they, you know, most times they'll come in, I have a sensation of something in my eye, or I feel like something's in my eye. And that's how you guys got to start thinking, okay, do they wear contact lenses? You know, do they sleep in them? What have they been doing? You know, ask about their proper handling of their contact lenses, things like that. So what would you see on a physical exam? So they'll have conjunctival hyperemia, so be red, maybe episcleritis or scleritis. But this one, a lot of times, if it's bad and your eye looks like that, you're going to be sending them to an ophthalmologist or an optometrist. Loosening of the corneal epithelium. That just sounds bad, doesn't it?
I'm really sorry.
So we'll refer them to an ophthalmologist. That's what we do. And they can look at, they will get a history of the patient. They'll look because they actually have better eye things than our ophthalmoscope to look at, and they can actually do a scraping of the eye, and they can see the amoeba. What they put it on, you know, scrape it and put it on a slide. They can probably see it under a microscope. Okay, treatment, so they'll give them some type of antiseptic agent such as polyhexamethylene, iodine, or chlorhexidine with or without a diamide. So it's basically an antiseptic with maybe a steroid in there, which we wouldn't be prescribing that anyway. The duration of therapy is usually 6 months to a year. You can give them pain control by giving them a topical, they'll give them a topical drop to numb their eyes. So prevention, how do you keep from getting this? Take good care of your contact lenses. Don't put it in your mouth and then stick it back in your eye. Don't touch your contact lens. My friend who has, now she's developed nearsightedness, farsightedness. She moves her contact lens over to read a paper. She does it all the time. She just like slide it over so she can read. And I'm like, how does this stay stuck over there? And I see her do it all the time, and it freaks me out because I feel like she's like just basically ripping off her cornea every time she does that. But that's what she does. So store your contact lenses well. Remove them at night. Daily wear. I'm a big person of daily wear. They're more expensive, but wash your hands before you put your contacts in. Clean your contacts like you're supposed to. Don't wear the ones that are weeklies for 2 months. That's a big thing. People like to do that. I was guilty of that. The ones that are like 1 month, I wear them for 2 months. I was guilty of that. Nobody? Let's see how text that and then just do this.
When I worked at Ophthalmologist's office, like no one got all the results.
Sometimes you have to exit the center mode and play it, and then just like play it on the screen. Like to where it shows just like the slides if you were looking, like going through to edit.
Do you guys see them?
Because I was really good about the 2 weeks.
Yeah,
I'm wearing my glasses. It's apparently not enough. I realized I have sinus infections all year.
You do the whole, like the whole PowerPoint thing.
Wow.
Yeah, I haven't had sinus infections or any kind of like
Does it wear those? They look good.
I talked to my doctor about it, and he was like, oh yeah, that happens all the time. I think I have really bad allergies. We should have done daily. I mean, I've had contacts since I was in 6th grade.
Are you serious?
Yeah.
Why don't these people pay attention somehow? I
I didn't know if that's like
Yeah.
daily. I thought they were just worms because they were
Yeah, it's more comfortable.
whatever. And I was like,
that
they're more
kind of stuff.
expensive. Oh, apparently I needed to be in daily before I'm not working.
See, I didn't even know that contacts were side effects.
Well, they just, I think it's the pollen and stuff gets stuck on the contacts, and then you take them out, and put them back in, but they're sitting in the water, pollen's in, and you keep putting them back in, and I guess they get protein buildup on them over 2 weeks and stuff like that.
You know, it seems simple.
Stage name Nils is an international musician. While he was on tour in Greece, his life was devastated by a parasite.
When I got back, I was in Paris actually, and I woke up one morning with just a slightly red eye, like conjunctivitis. Suddenly, things took a turn for the worse, and I woke up one morning, the eye was kind of frosted over, and I could no longer see through it. At that point, I realized that this was not a laughing matter.
When Nick visited the eye hospital for tests, they discovered that his eye had been invaded by microscopic parasites. Nick had worn contact lenses for years and was always careful how he looked after them.
I'd been educated by ophthalmologists that you never store your lens in water from a tap. But I was told it was all right to wash the lens container in tap water, and so I did that.
Nick's predators called Acanthamoeba are found in tap water, swimming pools, even in bottled water. They had entered Nick's eye through an insignificant scratch on the surface and made it their home.
They live there. They make a little city and they reproduce and they swarm around on the surface of your eye.
Nick endured months of treatment to try and get rid of the Acanthamoeba, but his eyesight continued to deteriorate.
I mean, I could try and look at a source of light and I would just see vaguely. I certainly couldn't see my hand. I mean, I'd see just a very strong light, possibly the movement of a strong light.
This moist, warm environment was perfect for these invaders. As they multiplied, they set about destroying his cornea.
I need hardly say that this is a very, very regrettable outcome of the whole infection, and you've had so many hospital visits, very considerable.
At his next visit to the consultant, the news was worse than Nick had feared.
It's really done terrible, terrible damage to the right eye.
There's no long-term prospect that I might see it again?
I think not. I don't think there's any realistic prospect at all of any useful sight returning in the eye. Most patients, I have to say, enjoy better outcomes, better results of treatment than you. But really, in your case, it really could hardly have been worse, and I quite understand and realise that.
I knew that there were dangers associated with wearing lenses, but nobody had ever warned me that you could get bugs in your eye which would destroy the whole surface of your cornea. I mean, that's scary. I still don't know quite how these little creatures actually do so much damage.
Now he has a new edge, you should be thankful.
Now it kind of reminds me of that, you guys are kind of young for that band, but it's called Dead or Alive, I think. Did you wear a patch or kind of like that groovy 80s band?
What are you supposed to wash your contact case with?
Well, that's why I wasn't sure. All right, so when you said that, I was like, I always wash my
Me
contact
too.
lens case with tap water.
I put it in the dishwasher. Every 2 weeks.
I guess you could rinse
Every
it with a
2 weeks, I
solution,
did it
dump
in
it out, and then rinse it
But
with a
what
solution
I mean,
bottle.
I change out mine a lot, but
I've kept the same contact lens case for who knows how long.
I change like what it compares like in the water the day after.
Every 30 days, you're supposed to get a new case?
Yeah.
Well, I never rinse it with the water.
Oh, I see.
Yeah, just like 30 years.
Do you not wear
Okay, now how do I get this to go back, Jenna?
I have phobia, girl. You
can just put next.
poke my eyes with my
Well, we'll talk about it.
Well, okay, there we go. I just had to get off of that. All right. So, be cognizant of your contact lens wearer patients and yourselves, so you don't get a frosty eye like that guy who have to wear a patch. Okay, so the next disease is granulomatous amoebic encephalitis. So this is rare, but it's usually a fatal disease caused by the Acanthamoeba. So it usually occurs in patients with weakened immune system, so I think a lot of them were AIDS-related patients that had this disease. They usually enter through the skin or the lungs and spread into the bloodstream. So signs and symptoms of Acanthamoeba would be mental status changes, they'll have loss of coordination, blurred vision. They can have skin sores if they enter through the skin and get into the bloodstream that way, but any other neurological symptoms as well. And how do you diagnose a patient with this? You get a CT or MRI. You can do a spinal tap and look for the amoeba in their CSF fluid. Biopsy the brain, or if they have a sore on their arm, you can biopsy the sore as well. And treatment is usually a combination therapy treatment, miltefosine and one or more antifungals and antibiotics. So that's really all you need to know about treatment for that. I'm not going to tell you specifics. Just know that it's a multi-drug treatment. Because, like I said, you're likely not going to ever encounter this in your lifetime, unless you work in infectious disease or rarely if you're working out in the country, out of the country. But a lot of times, most of the diagnoses are made post-mortem when they do the autopsy and they see it in the brain. Naegleria fowleri. This is the brain-eating amoeba. Have y'all heard of this one?
I was on the news for it. We were out at the lake that day, and the news shot us, and they're like, Lake Arcadia has brain-eating amoeba, and there's me and my stepmom and my sister floating on the lake.
I don't know why that makes me giggle. And then you are doing something crazy in the background. So this one, I think this was a couple years ago. Was it when that young lady that died out of Lake Arcadia?
Yeah, it was like, it was so hot that summer, and we didn't have any rain, so it's just like super stagnant water. And there we are, like, splashing around in the background. Like, brain-eating amoebas in the lake.
Getting a brain-eating amoeba?
Yeah.
So these amoebas cause an acute, usually lethal infection of the brain called primary amoebic meningoencephalitis. Usually in fresh waters, lakes, rivers, hot springs. So people are swimming in the waters or diving in the waters. So then they get up into the nasal sinuses that way. So if you're gonna dive in these waters, plug your nose. If you're gonna swim in fresh lake waters, plug your nose. But it rarely can occur, sometimes, but it's rarely, that it can occur in a swimming pool when they haven't chlorinated it adequately. But it's rare. So again, it has the same morphology. They're cysts or trophozoites. Again, it's the infective site. These are flagellates. They infect humans by penetrating the nasal tissue and then migrate up to the brain through the olfactory nerves. There's a nice little schematic for you. So signs and symptoms. These usually would start about 5 days after they're infected. They can have headache, fever, nausea, vomiting. The later stages of infection would almost be like a meningitis. They'll get the stiff neck, confusion, loss of balance. Sometimes they can have seizures, hallucinations, and then they can slip into a coma. Fatality for this disease is about 97%. That's not very good. Only 4 people out of 143 known infected individuals in the U.S. have survived. So from 1962 to 2016, there have been 143 cases, but only 4 of those people survived. There have been 7 cases in Oklahoma since 1998. So the progression of the disease is rapid, and they usually die within 5 days. Which is, I was like, wait a minute, it starts at 5 days. So you're telling me you just have the disease and you pretty much die the same day. And you have to start having symptoms. Because I think that lady at Arcadia, she died like within, I think, a couple days or something like that from when she was actually in the lake. I don't remember now. I should have looked at that case. But how do you diagnose it? Obviously, you do a CSF sample, biopsies, tissue biopsies, PCRs, you can culture for it. But again, this one also, a lot of times the diagnosis is made postmortem. I know they're not postpartum. And treatment for these is amphotericin B, or any of the other azoles and antifungals. Dexamethasone, they'll give that to help decrease swelling in the brain. And then there's a recent drug that's been approved, but it's called miltefosine. It's a breast cancer and an anti-leishmania drug that we'll talk about later. Sometimes they've been using that as well.
Did they report how those 4 people lived? Was it just pure luck that they lived?
Well, I think one of them was I want to say one of them was a child. He ended up surviving, but I don't know. I think maybe the younger they are, I mean, not young, but I guess depending upon how healthy they were as far as how they survived, that I can't be for sure.
Viewer discretion is advised. Nycleria fowleri is also known as the brain-eating amoeba.
If you get infected with the brain-eating amoeba, you're in big.
Sorry. See, I started that and I did it right, and then I kind of messed up.
In nature, viewer discretion is advised. Nycleria Naegleria fowleri is also known as the brain-eating amoeba.
If you get infected with the brain-eating amoeba, you're in big trouble. This parasite is an out-and-out killer.
But while its actions often have deadly consequences, the amoeba hijacks the brain for a benign reason: to find food and shelter.
Inside the brain, the amoeba has a perfect environment to feed and reproduce. You have food, heat, moisture. It's perfect for them to live their lives.
But by living their lives, these parasites endanger ours. The amoeba has a two-pronged attack. First, it hijacks the host cells using special feed called pseudopods. Then, the amoeba cuts a hole in the cell wall. And when the contents of the cell leak out, the amoeba eats them. Not only are the amoeba ruthless killers, they also have a cunning method of evading the body's immune system.
The amoeba can defend itself by forming a coat, which is called a cyst. And this coat surrounds the amoeba and is impervious to the host immune system.
When the body's white blood cells attack, the amoeba forms its protective coat. The white blood cells latch onto the coat, but can't get through. Then the amoeba sheds the coat and escapes unharmed, leaving the white blood cells behind. 98% of those infected with the Naegleria fowleri parasite die in less than a week, making it one of the deadliest parasites on the planet.
Naegleria fowleri lives in bodies of warm fresh water such as lakes and rivers in tropical and subtropical regions. The parasite can infect humans if contaminated water enters the victim's nose. There, the amoeba latches onto nerve cells in the nose and travels into the brain, causing a condition that is almost always fatal. Naegleria fowleri is a single-celled organism that typically lives in warm fresh water. It thrives in tropical and subtropical regions. Infection occurs when contaminated water enters the victim's nose. There, the amoeba latches onto nerve cells and makes its way into the brain. Naegleria fowleri infections have been reported in 18 U.S. states. The majority of cases have occurred in Texas and Florida. To minimize the risk of becoming infected with the Naegleria fowleri parasite, the CDC recommends that people swimming in bodies of warm, fresh water avoid getting water up their noses. The CDC also recommends not stirring up sediment while participating in water-related activities. In the United States, less than 1% of individuals infected with the Naegleria fowleri parasite have survived. In most cases, the Naegleria fowleri parasite kills its host in less than a week. Naegleria fowleri is most common in lakes and rivers of the southern states, but it's been found as far north as Minnesota and as far west as California. Cases of human infection with Naegleria fowleri are actually very rare. Since 2004, only 34 cases have been reported in the United States, and the majority of those cases occurred in Texas and Florida.
The same thing with business. They want you to know that. It's in one place.
Yeah.
This would be a case.
Yep.
How many of y'all have had headaches and thought you had a tumor? Anybody?
I thought that one.
Okay. So the next set we're going to talk about are the flagellas. Chagas disease, African sickness, and Leishmaniasis. Has anybody heard of any of these diseases? And I think it was last year or 2 years ago, one of the groups on campus went to, I can't remember which country they went to, but one of the ladies came back and was positive for Chagas disease. We're all freaking out like, I don't know what we're supposed to do with this.
The blood supply is tested for Chagas.
Huh?
The blood supply of the eye test for Chagas.
You do? I mean, I've never heard of it till last year. So I was like, oh,
Yeah, every single person who donates.
so donates its size. So these again just are some small microbiology about the gels. All right, so Chagas. It is caused by Trypanosomiasis, or is the bacteria that causes Chagas disease. It's endemic in Central and South America. I mean, a lot of times, like they said 8 million people in that country have it, but don't know that they have the disease. It's very common there. Transmission occurs through bites of the Trypanosomiasis bug, also known as the kissing bug. Basically, and then a lot of these diseases, there's two actually life cycles. They have the life cycle within the bug, then you also have one in the host. So most of the time we're just going to talk about the host one, because what happens in the bug is way beyond what we will ever need to know. So usually I just try to start it from the infected bug into the human host. So basically what they do while you're asleep, they like to land on your face, and they take a bite, usually on your face. And it is an infected kissing bug. But basically it takes a bite, and then it lays on your face or wherever next to it, and then you wake up and you smack your face, or because it's biting you, and you accidentally push some of that feces into your open skin, and that's how you actually get it. And this is also known as the American Trypanosomiasis. Or sometimes you'll wipe it, you'll scratch your face and you wipe it up into your eye. You can also get it from congenital transmission, so maternal to the baby, blood transfusion, organ transplantation, and then you can also get it from uncooked foods that are contaminated with the feces from that bug. And then you can accidentally get it from lab exposure. But a lot of times these are in the impoverished rural areas of Central America, South America, and Mexico. There's a nice little disease, too complicated. Just know that you get bitten by it, you accidentally inoculate yourself by pushing the feces into your open sore where they bit you. So Chagas disease presents usually in 3 stages. The acute one, you get swelling at the infection site. You can have fever, fatigue, body aches, kind of like just the prodromal of a viral illness, really. But then you can have eyelid swelling, like this picture right here. I think in those endemic areas, it usually occurs in a lot of times in children, but they are usually asymptomatic. But usually 1 to 2 weeks after exposure, you can start having symptoms. You can get around where the bite is, it's called a shagoma, or they call, at the site where the parasite is bitten, that swelling, the indurated swelling is called a shagoma. And then romagnocine is the inoculation of conjunctiva. It's usually unilateral, so you'll have edema of the eyelids with conjunctivitis, and you may have preauricular lymphadenopathy. But a lot of times, if you don't treat it in the acute phase, it can lead on, and they'll develop into a chronic phase. So then you have the latent phase, so those who test positive for the T. cruzi, but they actually do not have any symptoms. Kind of like latent syphilis, latent TB, all of those latent diseases. They may have it, but they aren't symptomatic. And then you can develop into chronic Chagas. And so these can last years, decades even. But these patients will start developing cardiac or GI symptoms. Like they can develop CHF or AFib. Sometimes they can just go into cardiac arrest. They can, and then with the GI symptoms, they may just have chronic abdominal pain, and then they can develop a megacolon. When you're in GI, did they show a picture of the giant megacolon? So these people can develop those as well. And how do you diagnose these? You do blood smears or tissue biopsies. They have screening serologic tests. You can do the ELISA, all of that kind of stuff. A lot of these, again, I would focus on that you can do blood smears, tissues, or you can have antibody blood work. I probably won't put little B, Elisa, EF, IFI, or... Yes, did you have a question, Leah? Or are you just stretching?
I'm stretching.
Okay. But once a patient is diagnosed with Chagas, you need to start watching them, monitoring them. So you should give them a screening EKG and chest x-ray so that if they are infected, you can watch them if they develop into chronic Chagas if treated, then they'll start developing other irregular EKG patterns and maybe infiltrate on their CH, on their chest x-ray or enlarged lungs, fluid on their lungs, things like that. And then you should also get them a echo or a EGD if they start becoming symptomatic, or a colonoscopy as well. Treatment is an anti-parasitic treatment for those with acute and reactivated Chagas disease, or someone with chronic who's never been treated before. Congenital infections are considered acute disease, so treatment is stronger recommended for adults up to 50 years of age. We have chronic infection who's never been treated or they've developed advanced cardiomyopathy from that. Did she talk about that first drug, benzidazole, in the lecture? For most, I think for both of the Trypanosomiasis diseases, benzidazole is a treatment of choice. And then these other ones, they're not FDA approved. But again, you most likely will not see it, but it does happen, like we saw it. And I don't remember exactly what they did for her. I think they ended up sending her to the health department, the patient who got, because we don't have any of that here. She got sent to the health department. And how do you prevent that? So a lot of times when people have these in those rural areas, they lived in the small houses with mud walls, you know, and so basically how they prevent it is plastering the walls and replacing thatched roofs, spraying of houses, and when you travel, don't sleep in those kinds of huts, and then use travel nets when you travel. And then the African trypanosomiasis. This is caused by Trypanosoma brucei. This is also known as the African sleeping sickness. Again, the vector for this one is the tsetse fly. I also thought it was tsetse fly, but it's tsetse. Tsetse fly. And these usually, again, you're infected when you get bit by one. And these can present in three ways. Cutaneous, hemolymphatic, and in the CNS. The reservoir is usually animals or humans. So basically this is a nice little So how do you get symptoms? So if you get bit by the tsetse fly, you can get a cutaneous lesion, and it's a chancre, not to be confused with what other disease that has a chancre? Syphilis. This is the trypanosomal chancre. And you get a little papule that develops where the tsetse fly bit you, and in about a week to 2 days, and it evolves into like a big, almost like a crater-looking lesion. It's red, it's painful, and then if you develop a hemolymphatic disease over several months to weeks, you'll get fever, headaches, rigors, and you'll get what's called a winter body sign, and you basically have lymphadenopathy of the posterior cervical triangle. So that's a picture of the chancre. And that's the posterior cervical lymph. And then the third is if you get infection into the CNS, you'll get persistent headaches, personality changes, and the thing here is why they call it African sleeping sickness is they become very somnolent. Like they get so fatigued they can't get out of bed, they're just in bed all day long. And so without treatment, these patients will slip into coma and die of undernutrition or they get secondary infections. So the sleeping sickness, African sleeping sickness, tsetse fly. And then how do you diagnose these? Again, take microscopic views of the blood or the tissue sample. So you can take a biopsy of that chancre. And usually the parasite lives on the outer edge of the chancre is where they would biopsy it. You can do a CSF culture and grow it out of the CSF fluid. Lumbar puncture should be done in all patients just to make sure that they do not have CNS disease. And then there's two ways to treat it: without CNS involvement, pentamidine, and then with is the other one. Again, I probably won't test you on the treatment. I just want you guys to know what bug it is and what the disease is and how it's carried there. And the different types that you can get with Acanthamoeba. Because I've never heard of these drugs, and I don't expect you all to have to memorize these drugs, because most likely, again, you won't be encountering these drugs. And if you do, you'll probably look it up in the properties when you have to, or you call the CDC and ask them, what do I need to give this patient? Again, prevention, avoid endemic areas. So wherever you travel, if you ever travel abroad, you always want to look and see where you're going and what diseases are endemic in that area, and protect yourself before you go. Wearing protective clothing to the wrist and to the ankles. What's so horrible is that they can bite through your thin clothes, so wear thicker clothing, not just a thin, it's cotton, make it thicker cottons. And then skin repellents. When I went to Vietnam, I swore I thought I was going to get malaria because it's endemic there, and I went during which is their winter, or no, it's our winter, but it's their winter, but their winter is 90 degrees with 80% humidity. Oh, it was miserable, and I was like, okay, it's starting to get dark, I'm going back inside. Because, you know, same thing as dusk to dawn, you're like, I'm not going out there. But I'm pretty sure I got bit by bed bugs while I was there at my grandmother's house. Okay. Leishmaniasis. This is what I like to joke, and I said that Professor Rourke had was leishmaniasis. Because did anybody get to see her skin lesions when she came back from Costa Rica? That, or she looked like she was a leper, one or the other, I wasn't sure. But that was horrible, but I don't think she got leishmaniasis. Again, she can be bitten by a parasite, but then actually develop the disease. She, I think, had an allergic reaction to the bite. But leishmaniasis is caused by a bite of a female sandfly, phlebotomy. So isn't that interesting? So they're bloodsuckers, and that's where the name phlebotomist came from these phlebotomine bugs. And these affect the poorest people on Earth because they have poor housing, poor nutrition, and they have a weakened immune system and just lack of financial and medical resources. It said there were 700 to 1 million new cases and 20 to 30,000 deaths from leishmaniasis annually. But only a small fraction of those who are infected actually develop disease. So that was interesting. So there are over 20 leishmania species and over 90 sandflies that are known to transmit, that's actually leishmania, sorry. I want to say leishmania, but it's leishmania. And again, these can develop in 3 forms: visceral, cutaneous, and mucocutaneous. And it's the same thing, like I said, with the mosquitoes. So if you're traveling to an endemic area, don't go out from dusk to dawn, because that's when these are the most active. All the flies are. So have you watched Naked and Afraid? Yes. I love that show. I'm obsessed. I love it when my DVR records 3 hours of it, because I tend to binge and watch it for 3 hours. But I could not handle it with the bugs. And you know, I was like, well, I watched one episode where this one lady, and I'm pretty sure it was sandflies, they trapped themselves, they put themselves underneath the floating raft that they had on the beach, and basically they just entrapped themselves with all these sandflies. And she was bitten up, I mean, it was so bad. And I was like, and it's either that episode or another episode where they said that if you put urine on yourself, it is a natural repellent to the sandflies or mosquitoes. It was one of those, but I was like, I like that episode of Seinfeld. When they went and pee on, no, was it Seinfeld? That was Friends. When Monica wanted Joey to pee on her leg because of the jellyfish. Okay. So the first one we'll talk about is the visceral. This one is fatal if left untreated. You'll have irregular bouts of fever, weight loss. You can have splenomegaly and hepatomegaly, and then you can also develop anemia. But these are common in Brazil, East Africa, and Southeast Asia. Sometimes, once a person is bitten, they can develop visceral leishmaniasis months to even years after they were bitten. Again, so if someone develops all these weird, just fever, weight loss, and they have a huge liver spine to present to you, you might even have to start thinking about when have they traveled, you know, when was the last time they traveled, those kinds of things. Or especially if they came back from a recent travel, you need to find out where they came from. And then cutaneous leishmaniasis. This is the most common form, what Professor Roark had, is cutaneous leishmaniasis. Because usually it occurs in U.S. travelers who go to Latin America, Costa Rica, people who are in the military that get sent over there and come back. Those were like in Iraq or Afghanistan. So these are the skin lesions. They usually develop into ulcers on the exposed parts of the body. And they can leave long scars, and then they can really disable the patient, especially if the scars, you know, on their face. 95% of the cases occur in the Americas, Mediterranean, Middle East, and Central Asia. And they actually said, I read this, which I thought was interesting. According to CDC, there have been an occasional cases have been acquired actually in Texas and Oklahoma. And then these symptoms usually show up weeks or months after being bitten by the sandfly. It's like, where do we even have, well, I wonder if it's that, what's that big flat area that people go to, the sand dunes in Oklahoma, big flat?
Great Salt Plains.
Yes, Great Salt Plains. But I mean, I don't know where they would get it in Oklahoma. I mean, they acquire it when they were here, actually, they didn't bring it from abroad. And then mucocutaneous. So with this, after they've gotten bitten, they get partial or total destruction of the mucous membrane of the nose, mouth, and the throat. 90% of these occur in Bolivia, Brazil, Ethiopia, and Peru. So again, visceral is the most serious, but the most common is the cutaneous. So left, visceral, you've got the big belly. Middle is the mucocutaneous, and then the right is the cutaneous. So I think what happens is when the sandfly, the parasite, the Trypanosomiasis, when they get bitten, I think somehow it moves into the mucus, the parasite moves into the mucus and the nasal mucosa, and then it erodes and eats away at their face. How do you diagnose it? Again, tissue biopsy the lesions. You can do a bone marrow aspirate, culture PCR. There is a rapid serologic test for leishmania. I spelled that wrong. It's not leishmania. Leishmania. But again, I don't. You know, most places probably won't have it. You have to send it off. Treatment. It's again a very complicated treatment. It's based on the strain, which of the many species of the sandfly that bit you. Again, it's hard. So you would refer them to an infectious disease specialist. Again, that miltefosine has been approved in 2014 to treat all forms of leishmaniasis. And a lot of times, a lot of the drugs that are approved, they're not approved or available in the U.S. Y'all want to take a break and then we'll finish off the rest?